Well, hello there, everyone. Nice to talk to you again. And we're going to have a very fun lecture here on oral surgery. Just a word of caution, there are a few blood, guts, and gore pictures, and I'll try to remember to warn you before getting to one of those. But this will be fun to learn about oral surgery. We are going to cover oral surgery in two parts. So this first podcast is part A, and we're going to cover extractions, reasons for routine or simple extractions. Those are terms that are commonly used. Multiple extractions, when we pull a number of teeth at one time, and a complicated extraction, meaning typically wisdom teeth, or a tooth is broken off, the crown's broken off, so we have to go digging for the root tips. So that would be called a complex extraction. Then we're going to talk about sutures, the post-op appointment, and alveolitis. In part B, we're going to talk about implants, a little bit about reconstructive surgery, surgical asepsis, meaning infection control specific to surgical cases, some medications that we might use, monitoring equipment, meaning we have some extra equipment that we use to help monitor the patient's vital signs. So we'll cover those quickly. And then just a few miscellaneous procedures, some cosmetic surgery, bone grafts, and oral pathology. Let's start with some reasons for doing extractions. Why would we pull teeth? First of all, we might pull teeth because we have some baby teeth that won't come out. That's called over-retained primary teeth, or primary teeth that are retained or left in the mouth longer than they should, and so we have to pull them out instead of them coming out on their own. Our patient may have severely decayed teeth. So when they're so severely decayed that we can't save them, of course we need to pull them out. And this is really sad. This here particularly is a case of what we call baby bottle rot, ECC, early childhood caries, rampant decay, all some terms here for decay on multiple teeth, and it's pretty severe before we finally get treatment for the patient. Then maybe we'll have a patient that has very crowded teeth. You can see that these teeth, there isn't enough room in their jaw for all of these teeth, so they're all jammed up, they're all crowded. So we might need to pull a few teeth in order to provide room for all of these. Usually what we'll do is we'll extract a premolar in each quadrant. So tooth back here, first or second premolar, and then when we put braces on, then the braces will allow to pull this cuspid down into place because there'll be room after this extraction here. And we'll get that tooth down, right down into place. Another reason why we might pull a tooth is if it is an extra tooth, so what we call a supernumerary tooth. You can see in this picture here at the bottom, kind of interesting, we've got an extra wisdom tooth. Notice here we've got our first molar, our second molar, our third molar, or our wisdom tooth, and then we have an extra one up here. Not terribly uncommon. Wouldn't that be a bummer? We also have ones down here, some extra teeth down here. Notice that they're usually just a tooth bud, meaning just the beginning stages of a tooth developing, and it usually doesn't develop into a tooth that is fully formed or even functional. They are rarely brought into occlusion and are functional. So here's another example, a little bud between the roots there and little extra tooth there. Another reason we might extract a tooth is that it's fractured, it's broken. So if this tooth broke down the root, now if it's just broken in the crown, no problem. We can take care of that, make them a new crown for the tooth. But if it's fractured down the root, then there's no saving the tooth. So we'll have to take out the fractured root pieces, or excuse me, fractured pieces of the tooth. Or maybe we'll have an impacted tooth. Impacted tooth just means that it's stuck. So you can see these wisdom teeth here, and certainly impacted teeth can be other teeth besides wisdom teeth, but they're not uncommon. For wisdom teeth, they're the most common tooth to be impacted or stuck. And you can see in this first case, they're horizontal, or they could be stuck vertically. Notice the complication here is that the nerve canal, which is what's in yellow right there, that nerve canal is intertwined with the roots. So we have to be really careful in this case to get this tooth out without damaging this lower nerve, which can be very complicating and difficult to manage, to make sure we don't damage that nerve. And here's what we look like after those wisdom teeth extractions. Now notice that these teeth are actually fairly small. Wisdom teeth, even though when you have them removed, it can be quite painful, and it feels like a huge hole in your socket in your mouth when you have your wisdom teeth removed. But they're actually typically fairly small. Then maybe we have had a root canal done, and the root canal procedure was supposed to clear up this infection here at the root tip, and it didn't. So notice we've got this root canal completed, but there's still an area of infection there. So if that's the case, we can try to retreat the tooth, meaning redo the root canal procedure. However, in this case, notice we have already put a crown on the tooth. And so how would we get into retreat this tooth here? We would have to either drill a hole through the crown or get the crown off in order to deal with the infection at the root tips. Or we just extract the tooth. And I shouldn't have used the word just, because there's really no such thing as just extracting a tooth. I'm sure I've mentioned this before, but when we pull a tooth, all kinds of other domino effect of problems happen. What happens is the adjacent teeth, well then, once this tooth is gone, the adjacent teeth will drift in or shift, which when those do that, shift and drift in there, then it changes the bite. We can have bone loss. Of course, the only reason for the bone to be there between the teeth and holding the teeth in, and again, the bone around the oral cavity is called the alveolar bone, and then it comes up between the roots and around between a multi-rooted tooth and between all of the teeth there. So alveolar bone. Another reason would be if we have periodontal disease. So periodontal disease, as I know we have talked about a number of times, is disease in the surrounding structures around the tooth. So again, prefix peri means around, and then dont is teeth, and al is condition. So condition around the teeth You can see here very well that there's no bone around this distal root of 30, and we've got infection all around here. There's no saving this tooth. And again, once we extract it, we're going to have a big gap here that we're going to want to fill in somehow to prevent the remaining teeth from still drifting in and from bone loss. And then lastly, another reason for doing an extraction is to remove remaining root tips. You can see there's a root tip left right here. That could have happened a number of ways. Maybe the crown was so severely decayed that the crown of the tooth broke off and the patient didn't go to the dentist and the root tip was left in the socket. And now they're at the dentist and we need to remove that, or even during an extraction. So look at, for example, here we've got this tooth right here, number 4, has a huge cavity there. And so if this patient were to let it go for a long time, again, the crown would break off and the root would be left in the socket. Now, when the root tip is this small, what might have happened is when the doctor went to extract the tooth, the crown broke off during the procedure for getting the tooth off, which is not uncommon. And then the root tip was way up here, and doctor couldn't get at it without causing more damage and left it. And then eventually, over time, it starts to work its way out, and we need to go in and at a later date take out that root tip. So a lot of reasons why we might have a remaining root tip left in the socket that we need to get out. So why would we choose not to extract? So we have one of these issues, but we're choosing not to actually extract. For example, the tooth that had a root canal that was unsuccessful. Do we have any other choices? Well, we could do what's called an apicoectomy, where we go in and surgically just remove the tips of the roots and leave the rest of the tooth there. So there are some reasons why we might not extract and try to save the tooth. And saving the tooth most of the time, if we can save the tooth, is the better choice than to extract because of, as I said, those many problems, domino effective problems that happen when we extract a tooth. If there's serious, severe, active infection, so there's a lot of infection around the tooth, we might just put the patient on antibiotics, help to reduce the infection before we extract the tooth. If we extract with a lot of infection there, a number of things will happen. First, the patient may not be able to get numb, so it's very painful. The pH in the infection itself kind of neutralizes the anesthetic, and therefore the patient can't get numb if there's too much infection present. So we're going to put them on antibiotics, send them home, get that infection down into a controllable amount, and then extract the tooth. If the patient has a serious illness of some other kind, that takes precedence. If they're a hemophiliac, which means they won't stop bleeding, so if we extract and they have a bleeding disorder, we would have to, they would bleed and bleed and bleed, so you would refer them to an oral surgeon who works in the hospital setting, and they would take care of the patient in a hospital setting so that they can control that bleeding. And then if the patient is pregnant and it can wait until after they deliver, that's the better option than to do surgery during pregnancy if we can help it. Now, obviously, if they really need the extraction and they're pregnant, not a problem. But if we can put it off, that's always a better choice. Actually, maybe not always, sometimes a better choice. Okay, so we're going to talk about a routine or simple extraction. Those terms terms are used frequently for an extraction that's easy to get out. So what's the criteria for a simple or routine extraction? Well, the patient has what we call a negative health history, meaning they don't have anything on their health history that's problematic, that we need to deal with. So they have a clean bill of health, is called a negative health history. The dentist uses local anesthetic only, meaning they don't need to have any type of deep sedation or go under general anesthesia. It's simply our normal anesthetic, local anesthetic is enough. It's just one or two uncomplicated extractions. It's not the whole mouth. And usually 15 to 30 minute chair time. It can be very quick. We get the patient numb, takes them 10, 15 minutes to get them numb maybe, and maybe even less than that depending on where in the mouth. And then once they're numb, we can very easily pull the tooth out within a minute or two, and they're on their way pretty quickly. Sutures are not needed. We don't have to stitch them up, and just some basic general home care instructions, nothing major, and they'll have discomfort for a day or two. Okay, warning, our first what you might consider gruesome pictures coming up next. Close one eye, look between your fingers, do whatever you need to if this will gross you out. Okay, as you can see here at the very top, we have a patient that only has a couple of teeth remaining. They've had other teeth extracted a long time ago. Areas are very healed, and you can notice here on the back left side that the bone has really resorbed. So those teeth have been missing for quite a while. So these teeth here are going to be very easy to get out, and you can see once they've been extracted what the remaining sockets look like. In the picture below here, notice that this patient has severe periodontal disease. You can see there's very little bone here holding the teeth in. No bone holding these teeth in right here. They're just being held with soft tissue. And so these teeth are going to be super, super easy to remove. In fact, this patient may be difficult to get them numb. But now remember I said multiple simple extractions are just one or two uncomplicated teeth. So I don't know, would this fall into a simple or complex extraction? We're splitting hairs, but these would be very easy to get out. So this is what your tray might look like when you are setting up for this procedure. Here's your instruments, and we're going to go through some of these instruments here individually in a second. Notice that we have a basic setup. Basic setup goes with every setup of instruments. And then we're going to talk about these here in just a second. You have some cotton pliers, of course. These are called hemostats. These two right here, hemostat, H-E-M-O-S-T-A-T, hemostat. These two right here, and you can tell that they're basically a cotton plier, but they have a little lock right here, so you can put something in it there, such as a needle, and we'll talk about that in a minute when we talk about sutures, and lock them into place in the hemostat. A bite block, of course, to help keep their mouth open. Different types of scissors. These ones here are suture scissors, and then tissue scissors are right here. We'll talk about those in just a second. We've got our forceps that's going to pull the teeth, our lip and tongue and cheek retractor, suction tip, and sutures. Again, be sure you take your dental instrument pocket guide and find, as we go along, find the instrument that I'm talking about. You're going to be in chapters 15 and 17. I would start with 15 right now, and that's going to have the basic instruments for a routine extraction in 15. And then 16, it goes over periodontal surgery, which we're going to skip. And then 17, a complex extraction, which we'll talk about in a minute. But make sure you have it open, ready to go, so that you can find the instruments as we're talking about them. All right, so mouth props, things that help keep the mouth open. Again, I showed you on the tray, bite blocks, very common to keep the mouth open while we're working. This guy right here, I don't know what its real name is, to be honest with you. I call it torture. This is the worst. I think this looks worse and is worse and scary than the forceps themselves. But there's a picture in your instrument pocket guide that shows what it actually looks like in the mouth. You might want to also Google it, maybe locking, put locking mouth prop or something, and see some pictures on how this actually looks and how it's used in the mouth to keep the jaws open. Not uncommon to use it in pediatric dentistry instead of the bite block, as the kid will sometimes spit out the bite block, whereas with this they have no control. We have the control because they don't know how to get it out. Anyway, personal opinion. Tongue-in-cheek retractors. There are a number of different kinds. Notice that this one here is from, I would assume, the University of Minnesota. I really never thought about this before. Everybody calls these Minnesota cheek retractors. So maybe they invented it at the University of Minnesota. I'm not sure. But anyway, these are commonly called Minnesota cheek retractors. And there are many other types of tongue-in-cheek holder. Now, one of the first instruments a doctor may use in order to loosen the bone and soft tissue from around the teeth is an elevator of some type. This particular one happens to be what we call a periosteal elevator. And it's fairly heavy and thick. And what we'll do is we'll slide it between the soft tissue and the tooth and peel away the soft tissue a little bit. That's called a periosteal elevator. So we're loosening the periodontal ligaments from around the tooth, breaking them actually, so that then the tooth is not adhered to the socket. And then we can pull it out. So that's a periosteal elevator. Another type of elevator is what we call a straight elevator. And again, depending on where we're using it, it does the same thing as a periosteal elevator, just breaks those ligaments or fibers between the tooth and the socket so that it's loosening that tooth. And these are also elevators, and they're properly called crier elevators. Not sure where that term came from, but some people will call it an east and west or left and right elevators. And a lot of offices will give these types of instruments their own special pet name that nobody knows but your office. But this one is fairly common because the tips here on these elevators can grab the tooth or grab between the socket or between the roots and help to remove the tooth. So the little point here on these are helpful in many cases. So these are pretty common. And then of course the forceps themselves that are going to be used to pull the tooth out. Notice here, and there's a few slides coming up next about forceps and how important the tip is and the angle of the tip. So you can see in this case there's a little off-kilter angle there. And then this one's just shaped fairly straight. This one is totally straight up and down. This one has a bend in it right there. So they're shaped specific for the type of tooth that you're extracting, and you'll learn which one goes with which, and we're going to go over all that in class. Here's a great picture on how the forceps work. So the forcep is seated as far apically as possible, meaning we're going to get those tips of those forceps under the gum tissue and get them down as low as possible. We can get them into the socket. And then the doctor is going to rock back and forth, and that's called luxation. Luxation is a fancy term for loosening the tooth in the socket. To luxate the tooth is to rock it back and forth and get it loose. And then we're going to do a slight lingual force used here in this particular case. We're going to rock back and going to rock forth until it's fairly loose. And then we're going to pull and typically twist at the same time we're pulling. So again, that's going to help break those periodontal ligaments that are holding the tooth in the socket. Here's a couple pictures on the illustrating how important the shape of the instrument is, and the width of the end or blade of the forceps being the right width for each individual tooth to pull them out. And we're going to show you this in class. We're actually going to have a couple of typodonts with all of the screws out of the teeth so that you can go in and extract teeth with the right forceps. So it'll be fun and educational. Here's another illustration of the type of forceps we would need in order to pull this tooth out. So it needs to be fairly wide here in order to pull out the upper centrals. Notice how far down we got this forceps down the root, and then I'm sure the doctor luxated, twisted, rocked, and then now we're pulling to get it out. Last one, and this is a very interesting one here. Notice that this particular forceps, the ends come to a point or prongs right there. And you'd say, well, what the heck? How would you use that with points to extract this tooth? You have to bury the prong into the tooth? No. What we actually do is we take these little prongs here on the forceps and we bring them down here. So we get these forceps down as low as we can below the gingival crest. Now it depends on where that gingival crest and the alveolar bone is. Typically in this case when we're extracting molars is because there isn't a whole lot of bone there holding the tooth in anyway. So the doctor will get this forceps so that these prongs actually go all the way down into the furcation area on both sides. And then when we pull this tooth out, hopefully we're going to get not only the crown but the roots as well, because we've got some leverage down deeper into the socket. So these prongs right here are for lower first molars, to extract those. And these forceps are very commonly called cow horns because they kind of look like, when you open them up, kind of looks like cow horns. So almost every office will use that terminology. Megan, will you go get me the cow horn plier forceps, please? And those are the ones you'd go get. All right, a few pictures again, a little bloody, guts and gore on multiple extractions. Okay, so you can see in this case we have some severely decayed teeth. There's probably a lot of bone loss. This one looks pretty bad as well. Looks like there's a bunch of plaque at the gum line there at number 6. So we're going to take them out, and again, could be very loose and easy to get out. Now a lot of times, as I mentioned before, it might be hard if a tooth is severely decayed, as in the case of tooth number 9 here. This tooth is pretty severely decayed, and when the doctor goes to extract it, he or she may break the crown off, leaving the roots in the socket. And if at all possible, we want to get those roots out. Sometimes it's not possible. Same thing with this tooth back here. That's going to be a big challenge actually to get out. So once we have extracted all the teeth, and you can see these open sockets, then we are going to prepare to suture or stitch this up. So if somebody has multiple extractions, what we can be doing is what we call an all-on 4, or an immediate denture, where we extract all of the teeth. So here he is. I don't know his name. Let's just call him George. We extract all of the teeth, and then notice what we do is we put in implants into the alveolar bone where the teeth are missing, and we want them spread out and stable if we're only going to use a few. Or we can go ahead and give them an immediate denture. So this would be something that would be bonded in to these anchors, implant anchors, and they can't take this denture in and out. Why would that be an advantage? Well, using those implants helps to stabilize the denture and to prevent bone loss. So those implants are really, really valuable. And you can see a difference in his smile from here to there. Look at the brightness of his eyes. He is happy, happy, happy with what they look like. Okay, and then here's just another example of an immediate denture. So we go in, extract the remaining teeth, and at the very same appointment, we put that denture in the mouth, right over those extraction sites, which you'll recall we talked about in the Crown and Bridge lecture. Doesn't feel great, but we want to get that denture directly in there over those extraction sites, and it's going to help to hold down or prevent swelling. You're going to tell your patient, do not under any circumstances take your denture out of your mouth until you come back to see us for your post-op appointment, which is usually 2 to 3 days later. And then we'll take it out, clean everything up, check the healing of their tissues so far, and give them back their denture. And if they're not healing very well, certainly we'll take steps to deal with that, be it put them on antibiotics or whatever the case is. Okay, for complicated extractions, what's the difference here between a simple extraction and a complicated extraction? All right, one of the first things that is different about complex surgery or complicated surgical procedures versus a simple or routine extraction is that it usually takes 3 appointments. The first one being a pre-op appointment, meaning we bring them in and we do a consultation or treatment plan. So you will bring the patient back to an operatory, review their medical history, make sure it's clear and everything is accurate on it, take their vital signs so that we know what their normal baseline vital sign is, and then we're going to provide them some pre-operative instructions. So if the patient comes in and says you need to have 6 teeth removed, then before your next appointment, when you come in to have them removed, we need you to XYZ. First one being, we need them to fast. Do not eat after midnight the night before. That is really important. One of the biggest reasons why oral surgeons carry high malpractice insurance is for this reason, so that if a patient gets nauseous during the middle of a procedure and aspirates their own vomit, meaning their vomit goes into their lungs, that can be life-threatening. So we want their stomachs empty, so that if they do feel like vomiting, there's just nothing that will come up. There's nothing there. And then we might offer pre-meds. So this would be an anti-anxiety pre-med, meaning some Valium, lorazepam, something that they're going to take before the appointment to make them a little bit more comfortable, a little bit more woozy, a little sedated feeling, and relaxed. Next, we will, oh shoot. Then there's the surgery appointment itself. So again, what are you going to do? You're going to set up the room, get it ready to go. You're going to seat your patient. Again, we would review their health history. Even if it was just the day before, you want to ask them, hey, has anything changed since the last time we saw you? And make sure you know that. And certainly prepare the room, get everything ready to go for the surgery. So you're going to set up the operatory, assist the doctor when needed. Most of the time, most doctors want an assistant while they're working to help them. So you should be in there if it's your job. And then providing post-op instructions is really critical. We're going to talk about that here in a second. And you're going to provide those post-op instructions. And then lastly, we will pack some gauze in their mouth over the extraction site, tell them to close down, leave it in there for a couple of hours at least, then exchange it with some new 2x2s that we typically give the patient, and they should see a sharp decrease in the amount of blood flow coming from that socket. So then they're going to come back a couple days later, usually 2 to 7 days later. Most common I would say is probably 3. And then at the post-op appointment, you're going to check for healing, make sure it's healing correctly, and you might remove some sutures. And yes, you might remove some sutures is the operative word. That is a DA function. Believe it or not, any dental assistant can remove sutures. So here is a complete tray setup for a complex surgery, and you can see that there's a lot more here than was on the original routine extraction tray. Some things you'll recognize already. There's a few new ones, like for example right there is called a curette. We'll talk about that in a second. There's a bone file, excuse me, not a bone file, a rongeur, which cuts the bone off, and then a bone file right here. And this is a mallet and chisel. I used to think these were obsolete and no longer used, and my son was telling me just the other day that his doctor used a mallet and chisel. So they certainly can be helpful in breaking apart pieces of the tooth if we need to. You can see here's the cow horn forceps. We might need burrs because we might need to do some drilling to get the bone away from the tooth. We've already talked about a surgical suction tip, bite block, Minnesota, cheek, tongue, lip retractor. These are tissue scissors, and then these are suture scissors, where we're going to put the suture in that holder, and then tissue scissors over here. All right, so the first extra instrument that they'll have in a complicated surgical procedure would be a scalpel, or what is properly called a Bard Parker. Bard Parker, and that would be a term that I would definitely know, if not for the purposes of in your office, but on the RDA exam, I'm sure they use the term Bard Parker instead of scalpel, just to test your knowledge of the word. Now we can use both disposable scalpel on a disposable handle, and you just throw the whole thing away when you're done, or you can use metal ones where you slide the blade right onto this end of the holder for the needle and use it. And then this right here is a remover, so it helps you remove that scalpel blade from this metal handle that we're going to sterilize without hurting yourself. In your office, you might have some different high-speed hand pieces than what you use for other restorative dentistry procedures. The reason for this surgical handpiece is so that, as you know, handpieces are powered by air, and so there's a lot of air force coming out of the front in association with the fluid, whatever fluids you've got in there to help it rinse. But what happens with a surgical handpiece is instead of the air pressure coming forward, the air pressure is actually vented backwards. And there's a couple of critical reasons for that, and we won't go over it right now. But you want the air to come out the back of the tip of the high speed instead of out the front. Notice, of course, what would indicate a difference here for you would be this piece of equipment here with a hook, and your sterile water is right up here. So we are reducing or keeping a lid on the bacteria count in the water lines by using sterile water. And then we might need to use an irrigating syringe, or called a Luer lock syringe, which you should be familiar with those now. These particular ones are called monojet syringes, where they are bigger than a Luer lock, but look just like a Luer lock. And we use it with some warm salt water or hydrogen peroxide to help rinse out the socket. Warm salt water will help the healing process, and salt is a little bit of an antibacterial agent, so it'll reduce the bacteria count. It provides a little bit of a soothing feeling, and so that's always a good thing, warm salt water or hydrogen peroxide, which helps to bubble out the active ingredients in it, will help to bubble out the debris out of the socket, so we can leave the patient with a nice clean hole without debris in there. And you might even give the patient a monojet syringe to take home with them if you do not place sutures, and tell them to use it after 24 hours. You don't want to use it before 24 hours, but after 24 to 48 hours, they can start using it if food gets stuck in that socket while it's healing. All right, and then surgical suction tips. They look just like regular suction tips, but notice they come to a point or a taper at the end. And the purpose for that is so that we can actually get this suction tip directly into the socket where we are working. Now you want to be careful with that, because sometimes you don't want to do that, especially on the upper arch in the molar, premolar area, because you might actually suction the lining of the sinus, and we don't want to do that. So follow the doctor's instructions and lead as to where you put these surgical suction tips. Okay, some tissue forceps. So they're like cotton pliers, but they're made specifically to hold the tissues. So you can see little buttons on the end here. They'll hold the tissues tight for you while you are placing a suture. And again, placing sutures is not you. I'm using the collective word you, meaning your doctor is going to use the tissue forceps and hemostat with our needle on it to pull the suture through the contact and then create a knot here to close it up. A couple of scissors that we use. Tissue scissors on the left, obviously used to cut tissue, and certainly we could use them to cut other things. We use them to cut bleaching trays. Remember when we cut your bleaching trays, when you made those, you'll use some tissue scissors for other things as well, but they can be used to cut some gingiva or soft tissues. And then these are suture scissors. So these are used when we go to remove the suture. We can put this little scoop part underneath the suture and then squeeze and cut off the suture and then pull it out. And I'll show you more about that in just a second. And as I mentioned a few minutes ago when we were looking at the tray, we have what's called a mallet and chisel. What happens with this, and it sounds barbaric, but it works in certain situations, where we take this chisel and we put it right between the crack somewhere that we want to break open the bone or break away the tooth from the bone or break the fragments of a tooth. And so we put the chisel right where we want the break to be, and then take the mallet or hammer and whack the end of the chisel, and we then fracture the tooth or bone however we want to do it. I used to think these were obsolete and not used anymore, and apparently that's not the case. My son was just telling me the other day, he works in an oral surgery office, and they did this the other day. And interestingly enough, often the doctor will place the chisel where they want it, and then the assistant is the one who actually takes the mallet and hammers the end of the chisel as instructed. I've never done it before. Sounds crazy, right? All right, and then these look like forceps, but they're not. They're called a bone rongeur. You have to be French to say this word, rongeur. You have to plug your nose when you're doing it. But notice here on the very tip, there are two blades, or the blade actually comes down here and around the edge, and they have the same thing on the inside edge of the other side. So what happens is we bring it to the bone and we take little jagged edges that we want off, and we snip them off with this bone rongeur. So those little edges here on the tip of the rongeur are sharp, and we're clipping off jagged edges of bone. We don't want to leave any jagged edges. That's going to hurt the patient as they are biting down, and it's also going to be a great place for bacteria to harbor. So we want to trim off any jagged edges of the bone, and then we're going to file it. And gross picture coming out here next, I think. Not too bad of a gross picture. Hopefully you can handle this, but notice what we have is the soft tissue is cut off of the bone. Here is the bone. Okay, and their teeth were extracted quite some time ago, because you can see everything has kind of healed up and collapsed in. But for whatever reason, they cut off the soft tissue here, and then are going to use a bone rongeur to cut any jagged edges. And notice here, this is a bone file. Oops, sorry, I keep doing that. A bone file that, just like a fingernail file, is sharp, and will go back and forth on the bone until it is super smooth. Again, to make sure that there isn't any jagged hiding places for bacteria. Once we use the bone file, there's going to be, just like when you file your fingernails, there's some dust particles from your nails all around, and you then go wash your hands. We use in the oral cavity, after we use a bone file, is take what is called a curette, which is a spoon, and there are different shapes and sizes of curette, and so the doctor will go in and scoop out any debris from the socket. And then, as I mentioned before, we might need to get out root tips. How do we do that? Well, we use these instruments right here called root tip picks. They look like a straight elevator, but they're a lot skinnier, and we should be able to slide this root tip pick into the tissues, get it up in here, and wiggle, wiggle, wiggle this tooth out. So we keep wiggling it, and hopefully the whole thing will come out at some point. Phew, once we're done with all of that and we've extracted the teeth, we have used the rongeur and file and cleaned out the socket, we are ready to place sutures. There are basically two different types of sutures. There's what is called black silk suture that is actually made out of silk, and of course they're attached to the metal needle here, and it does not dissolve. So once it is placed into place and we wait for the healing, usually 5 to 7 days later, we have the patient come back for a post-op appointment, not only to check the healing, make sure they're doing okay, check their immediate denture if they have one, whatever, but also to remove these black silk sutures because they have to be removed. Now, there are some dissolvable sutures that are called catgut sutures, and the funny thing is that they're not made out of cats, but out of sheep's intestine. So the catgut sutures actually are tissues from a sheep's intestine that when it is used deep in the jawbone. So sometimes the doctor will have to do some sutures down deep in and then put the black silk sutures over the top. So of course the sutures that are within the alveolar bone and not on the top surface, we can't use black silk because we'd have to go back in, open it back up to remove them. So you can use dissolvable ones. There are plain dissolvable or catgut sutures that dissolve in about 10 days, and then there are ones that are called chromic sutures that dissolve in about 20 to 40 days. Again, doctors discretion or determination what they want to use. The black silk, however, being the most common, and really the reason for that is because we want to enforce our patient coming back for their post-op appointment. Their healing is our responsibility, and we want to make sure that they're healing nicely. So if we put the dissolvable sutures in, they may not come back for their post-op appointment. And then if they have active infection and a problem, we are responsible. So we need to get them back into the office. So we usually will place black silk ones so that if for no other reason them showing up for their post-op appointment, they want to get those sutures removed. So how are sutures placed? Well, we pass the suture in a hemostat. Remember these locking instrument that locks, and it kind of looks like a locking cotton plier, or this end looks like a scissor tip. So you're going to put the suture into that hemostat at a T, and what we mean by that is here's the hemostat like this, and you want the suture coming across here at a T, and that has historically been a question on the RDA exam. Now we're going to hold, when we go to pass it, we're going to hold the hemostat by the hinge right here up towards the top, so that we're then putting the thumb and finger rings directly in the patient's hand, and they should be putting their thumb and their middle finger directly into those rings or circles there in the hemostat. The doctor will either place a continuous or interrupted suture, and exactly what it sounds like. A continuous is 5 or 6 stitches just continuing like you're hemming a gown of some kind, or interrupted sutures where what they're doing is after each time they go in, slide the needle under the tissues, then they knot it off, cut it off, and start over again in the next tooth. So, or next area. So take the hemostat, slide the needle through the tissues, and then put a knot in it, cut off the excess, and continue. So they're interrupted. Now, one of your jobs during this procedure, besides passing the hemostat and making sure to pass it correctly, will be once they are passed and the doctor has placed the suture, you might need to cut off the end of that suture, leaving, and again, this has historically been a question on the RDA exam, leaving the pigtail that's remaining, or the little tiny bit of suture thread is hanging out of the mouth about 2 to 3 inches, and then or excuse me, millimeters, not inches, millimeters, and then we cut it off there. You don't want it too long that the patient will actually play with the end, or too short where the knot will unravel. Okay, and then post-op instructions. We're going to give both written and verbal post-op instructions. These are so important that we need to give them to them in two forms. We're going to tell them what their post-op instructions are, and then, whoops, other way around. We're going to tell them what their post-op instructions are, and then we're going to give them a little sheet of paper with them all written down. Now, let's say your patient is a patient that we have given a conscious sedative to, or a medication to make them groggy, woozy, out of it. We certainly don't want to give them verbal instructions while they're under the influence of those medications. They won't remember what you told them. So that's why we give them to them in writing. You might also need to give those instructions to their caregiver. So maybe your patient and your protocol is to have the patient actually take the medication, the Valium, the sedative, whatever it is, on their way in 15 or 20 minutes before their appointment. They walk in already woozy and groggy and don't know what you're saying really, in which case you're going to give those instructions to the caregiver, whoever brought them in, again, both verbally and in writing. So those instructions include do not, very, very important, not to rinse at all. Don't rinse your mouth at all for 24 hours. The reason for that is because we do not want the blood clot to come out. We want the blood in the socket to stop bleeding or coagulate. And if we rinse for any reason or cause any fluids to go in there, do any type of sucking motion that will pull that blood clot out, it is very, very painful. It's called dry socket or alveolitis, and we'll talk about that next. So definitely really important. No rinsing the socket for the first 24 hours, and then after the first 24 hours they can use warm salt water. Again, it'll be soothing and have a little bit of an antibacterial component to it. Tell them not to smoke or use a straw, again for the same reason here, so that they do not pull that clot out of the socket. You want them to limit their exercise for a couple of days. They can use ice packs, 10 minutes on, 20 minutes off, 10 minutes on, 20 minutes off, and continue that within the first week, or excuse me, first day. And they have to do it right away when they get home. Start using that ice pack, not wait too long, because once the reason for the ice pack is to prevent swelling. It does not decrease swelling very well, but it does a good job of preventing swelling. So we need to get that ice pack on right away, even while they're still numb. In fact, the office may even give them an ice pack to hold on their cheek while they're on their drive home. And again, it'll make it feel a little bit better, but it also prevents swelling. Take medications as prescribed. Absolutely no aspirin. Remember, aspirin thins the blood. So they're going to bleed more if they take any type of blood thinning medication. And aspirin, a very common one that people might want to go to if that's their drug of choice when they have a headache or whatever. But definitely no aspirin after an extraction. They will bleed, bleed, bleed. Don't brush the area for the first 24 hours, and then limit diet and no alcohol, meaning don't eat a whole lot, definitely no drinking alcoholic beverages, and hopefully if they follow these instructions everything will heal nicely and we won't have any complications. So then our last appointment, remember we started at the beginning here of this complex procedure, 3 appointments: pre-op, surgery, and post-op appointment. The post-op appointment is usually 5 to 7 days after the surgery. We want some healing to take place first. We're going to get them in, and the first thing we're going to do is just check the site for healing. So we don't want it to be super red. This is a little bit more red than we'd like to see it, but We'd also look at it in conjunction with, is it swollen or is there any swelling? How clean the sutures are. Is the patient taking good care to try to keep the areas clean, which will help prevent an infection. So we're just checking first to check the site for proper healing. The tissue should start getting tight, should not be real red or swollen. Okay, so suture removal. Believe it or not, bottom of the page here, yes, in California, a DA under direct supervision can remove sutures. You might be called upon to remove sutures your first week on the job. It's really not that hard. Sounds like it's complicated and hard, but it's really not that hard. So what we do is we first take a cotton swab, like our Q-tip, and we're going to just lightly wipe over the wound and clean any plaque or yucky stuff, food debris, whatever, over those sutures. And then we're going to use cotton pliers here and hold the knot. So make sure that we're grabbing where the knot is in the suture with a hemostat or cotton pliers. And then we're going to use our suture scissors, where here's the little scoopy part of the suture scissors, and you're going to scoop that underneath the suture and snip them. And then you want to make sure when you're pulling the suture out, you have a good grasp on the knot itself, so you're only pulling the other opposite part through the tissues. You want to make sure not to pull the knot. Do not pull the knot through the tissue. That would hurt. And then we're going to place the removed sutures on a 2x2 so we can keep count. If the doctor did not do a continuous suture but did individual ones, if they placed 6 individual sutures, how many should you remove? 6, right? Duh, obvious. However, it is not uncommon for some sutures to actually pull out of the tissues between the surgery appointment and them coming in for this post-op appointment. And usually the reason for that is because there was some swelling that took place. The suture stretched a little bit, but then when the swelling went down, the suture is still stretched out of shape, and so it is fairly large. It's not tight to the tissues, and so if it's hanging out there and fairly large, they'll play with it with their tongue or whatever and it'll fall out. So usually if 6 sutures were placed and when you go in to remove them there's only 5 there that you can find, you certainly want to tell the dentist that you only found 5, though you realize 6 were placed. They're going to do a double check also to make sure you're not just missing them, but probably what happened is the suture came out, and that's usually a sign on its own, and that's usually a sign of healing, or a good sign and not a problem. We just don't want to leave it in there if it's still there. So as you remove them, put them on a 2x2 so you can count them, and then the doctor needs to come in and do a final check and make sure the patient is healing well. You did a good job removing the sutures, and we can send the patient home. And here's some before and after pictures. So here's some sutures that were placed. You can see these ones are pretty tight, which is kind of unusual. It looks like we still have quite a bit of swelling here. So if you were going to remove these would be a little harder to remove, as the suture looks like it's fairly tight. But again, you're going to grab the knot. So right here, you're going to grab this little knot with the hemostat or cotton pliers. Take your suture scissor, go underneath the suture here with that scoop of suture scissor, cut it, and then pull the knot out. And this is what it looks like after, with direct. And of course we have quite a bit more healing to go, but not too bad.